A very good morning to all. Today I will be talking regarding surgical management of severe dry eye. So in the DUCE 3, there is some change in the focus as earlier speakers told. The traditional definition of severe dry eye in the symptoms scores were more than OSDI more than 33 and ocular surface staining more than 3. But the severity in the DUCE 2-3 update is the level of homeostatic threat and not just symptoms. And a patient becomes refractory when the underlying anatomical and physiological defect is not correctable with medical therapy alone, and surgical intervention becomes necessary to restore the ocular surface stability. So these are the 4 points which are highlighted in the clinical profiles as refractory or severe DED, that is absolute aqueous deficiency, seen in that's a total lacrimal gland failure in Sjogren's graft versus host disease, Stevens-Johnson syndrome, etc. And neurotropic keratopathy in which persistent epithelial breakdown despite adequate lubrication, and anatomical incongruence as in lack of thalamus, entropy on conjunctival etc., where topical therapies are ineffective, and persistent epithelial defects not healed after 2 weeks of intensive therapy, which suggests limbal stem cell dysfunction and altered cytokine environment. So indications of surgical intervention are medical therapy failure, severe aqueous deficiency, exposure or neurotropic keratopathy, meibomian gland dysfunction, anatomical abnormalities, and surface reconstruction needs. So according to the DUCE 3 framework, if the as it is a new concept of the driver is introduced, in which if the Schirmer test is less than 2 millimeter and there is severe aqueous deficiency, salivary gland transplantation, and if in neurotropic keratopathy, if it's severe, then corneal neurotization, and if there is eyelid anomaly, then tarsorrhaphy or gold white implantation or canthoplasty. And in recurrent plug extrusion or stenosis, then thermal punctal cautery, and non-healing epithelial defects more than 2 weeks, amniotic membrane transplantation. And if there is surface disorders like pterygium or conjunctivochalasis, then autograft or conjunctivoplasty. And in obstructive MGD, refractive to compression and medical therapy, intermittent thermal pulsation and probing. So punctal occlusion is one of the common procedures we do when the shimmer value is less. There are 2 types, collagen plugs and silicone plugs. Collagen plugs are temporary, which dissolve over 4 to 7 days, and silicone plugs, which is semi-permanent. It is minimally invasive, quick office procedure, but you should make sure that the patient is having severe aqueous tear deficiency, otherwise it can cause epiphora. The complications are spontaneous plug loss, canaliculators, or granuloma formation. This is very simple procedure. This is a silicone plug which can be implanted in your OP with the skillet. You can just implant it and keep it there. It improves the tear film retention in your eye drops in the eye, improving the tear film symptoms and ocular surface as such. Then permanent punctal occlusion is indicated in severe aqueous deficiency, unresponsive to plugs are intolerant. You can use either thermal cautery or electrocautery. Its long-term effects benefits are sustained tear retention, but there is a potential risk of epiphora, and it's irreversible. And another problem is when you do cautery, there is a high chance of recanalization, around 20 to 25%. Mainly, there are some studies which show that it's due to the use of steroids in the initial phase. So steroids should be avoided for 7 to 10 days. Only use lubricants and NSAIDs, which will lead to better fibroblastic proliferation and better occlusion. Meibomian gland procedures targeting the lipid layer of the tear film. Thermal pulsation, that is LipiFlow and similar devices applied to control heat and compression to the inner eyelid, liquefying and expressing the mebum. And intense pulse light therapy to reduce periocular inflammation and telangiectasia, which will improve mebum quality and modulate inflammatory mediators. And meibomian gland probing can also be done to break the periductal fibrosis and open cystinotic orifices in focal obstructive disease. So conjunctival procedures like conjunctival recession in conjunctivochalasis can give symptomatic relief to a certain subset of patients. Amniotic membrane transplantation is one of the common procedures which will improve the epithelialization, reduces inflammation and inhibits scarring. It's particularly useful in persistent epithelial defects, unresponsive to medical therapy, and severe ocular surface disease and inflammation, chemical or thermal injury, and unresponsive recurrent corneal erosions. So these are available in different types. This is a dehydrated amniotic membrane graft called Omnigen, in which you can store it for a much longer time, or dehydrated freeze dried also is available. So you can apply it over the persistent epithelial defect and either suture it or with use glue. Then eyelid and lacrimal procedures, lateral tarsography, which will give partial fusion of lateral eyelids causing palpebral fissure width decrease, and effective for lagophthalmos and exposure keratopathy. And eyelid malposition correction of ectropion and tropion, etc., optimizing tear distribution and eliminating corneal irritation. And eyelid weight implantation for basically facial nerve palsy, restoring protective blink mechanism. So advanced ocular surface reconstruction in who are non-responsive to other measures, either by limbal stem cell transplantation, it can be autologous or allogenic stem cell grafts, restore the epithelial regenerative capacity, and keratoprosthesis, in which all the other treatments fail. To summarize, the key takeaways are surgical interventions of dry eye disease are reserved for refractory or severe cases after exhausting all medical management options. A systematic etiology-based approach optimizes outcomes, and therapeutic targets are tear retention through punctal occlusion strategies, gland function through meibomian gland stimulation procedures, improve eyelid mechanics through malposition repair and protective measures, and surface reconstruction in late or unresponsive cases. The treatment must be individualized based on disease etiology, severity, and patient-specific factors, and ultimate goal is restoration of ocular surface health and meaningful improvement of visual function and quality of life. Thank you.